So talking about urethral strictures with urologists really means addressing a fundamental pathology in urology, one that we have all encountered before, regardless of our area of expertise or our level of experience in the specialty. Nevertheless, a number of general concepts require clarification. The first is the definition of a stricture. The definition of a stricture is a narrowing of the urinary canal that is less than 16 French. It's simple. That's the size of the flexible endoscopes we use during consultations. If we can't pass the endoscope through the urethra, we're dealing with a stricture. Nevertheless, we can clearly see that there are different situations, as illustrated in these two images, particularly the severity of the stricture, which will need to be clearly specified during the initial assessment. It is important to review the anatomy and accurately locate the urethral stricture. The location of the stricture is very important because it determines the number of endoscopic treatments, as well as the type of urethroplasty that can be performed. Thus, the anterior urethra is surrounded by the corpus spongiosum and consists of three parts: the meatus, the navicular fossa, the penile urethra, and the bulbar urethra. Next, there's the posterior urethra, which includes the membranous urethra, the prostatic urethra, and the bladder neck. Based on frequency, we know that strictures mainly affect the anterior urethra, particularly its bulbar portion. This is why 3 years ago, the first recommendations were made only for strictures of the anterior urethra. And with this report, we hope to be able to broaden these recommendations to cover all situations that may be encountered. Although this is a long-standing condition, we have extremely little epidemiological data on strictures. We always refer to the same study, which is a North American study based on the Medicare health system. This study reported an incidence of urethral strictures between 200 and 600 cases per 100,000 people, with a prevalence of 0.9%. Nevertheless, this study is old and dates back more than 20 years. So, as a preliminary step for this report, we wanted to obtain results on the epidemiology of urethral strictures in France. Therefore, we analyzed the C-scan procedures and the number performed for this condition, and we realized several things. On the one hand, over the past 10 years, about 20,000 surgical procedures have been performed for urethral strictures. In 95% of cases, these are endoscopic treatments. This figure is probably underestimated, moreover, because we did not include in the study patients who perform self-dilatation at home, nor those who come to the urology consultation, or even to the specialized nurse for heterodilatation, were not included. The number of urethroplasties remains low, but what is encouraging is that over the past 3 years, there has been a significant increase in the number of urethroplasties, which shows that the messages we are trying to convey seem to be getting through. Regarding the etiologies of strictures, the causes differ between the anterior urethra and the posterior urethra. For the anterior urethra, although we strive to identify a cause, most of the time, the main cause remains idiopathic. In second place, we have iatrogenic causes related to urological procedures, whether catheterization or endoscopies. In third place, we have traumatic causes related to straddle injuries or blows to the perineal area. We could also add bicycle accidents, and we hope that the cycling events at AFET won't increase the number of urologists affected by strictures. Lastly, we find inflammatory causes, notably an increase in lichen sclerosus. Lichen sclerosus is a skin disease, but it can infiltrate the urethral mucosa and cause strictures. We know that lichen sclerosus is on the rise throughout Europe, and it's going to become a leading cause of strictures. In the posterior urethra, the situation is simpler. There are two main causes. The first is the iatrogenic cause related to treatment. Prostatic pathologies, traumatic causes in the context of polytrauma with pelvic fracture. A brief focus on iatrogenic etiologies of urethral strictures. We know that urological procedures are a source of urethral strictures. Thus, regarding urethral catheterization, catheter placement, or cystoscopy, they cause 3% of strictures, mainly located at the bulbar level. As for surgeries for benign prostatic obstruction, the numbers are somewhat higher, ranging from 0.3 to 13%. The particularity is that they can occur either in the anterior urethra, at the bulbar portion, or at the bladder neck, and the management is completely different. Regarding treatments for prostate cancer after radical prostatectomy, 1 to 3% of anastomotic strictures occur. Thanks to the use of the robot, this is decreasing, but it still exists nonetheless. The last situation is high energy treatment for prostate cancer. This is responsible for strictures in 1.5 to 1.9% of cases at 4 years. And we still have the impression that this number increases over time. We will now address the concepts of grafts and reconstruction. First of all, a good reconstructive surgeon should not persist with endoscopic treatments. Indeed, on the one hand, it will be ineffective for the patient, but on the other hand, it will make the stricture more complex. Indeed, by repeatedly performing endoscopic treatments, the stricture will no longer be just mucosal, but will extend to the entire spongy body, which will complicate the situation by lengthening and worsening the stricture. The second concept is the principles of urethral anastomosis or resection anastomosis. We hope that this report honors the father and founder of French urology, Félix Guyon, because more than 100 years ago, he was one of the first to describe the technique of resection anastomosis as an alternative to the blind dilations that were performed at the time. From this arose the principles for performing these anastomoses, which must be carried out on healthy mucosa, with spatulated ends, without any tension, and in a watertight manner, and with absorbable sutures. If excision anastomosis cannot be performed, then another tissue will need to be used. Currently, the preferred tissue is buccal mucosa. Why? Because it is a moist tissue that resists the acidic pH of urine well. It has a high graft take rate and low contraction. The rate of complications related to this harvesting is also low. Thus, it has become the tissue of choice and surpasses the use of skin tissues that were previously used but whose results were less satisfactory. Moreover, with the increasing incidence of lichen, we will be able to use skin less and less in these reconstructions. With this tissue, two main types of urethroplasty can be performed. The first type of urethroplasty is enlargement urethroplasty. The goal, therefore, is to widen the hemicircumference of the urethra with another tissue in order to restore a satisfactory urinary channel. The second major group of urethroplasties are replacement urethroplasties. At that point, we remove the entire diseased urethra and replace it. In the first surgical stage, we excise the urethra, place a buccal mucosa graft, wait for this graft to become properly vascularized and heal, and then in a second stage, usually 6 months later, we perform urethral tubularization. The main takeaway from this presentation is that currently only 5% of procedures for urethral stricture are urethroplasties, and we hope that this number will increase. With these fundamentals in mind, Nicholas, you can now tell us about the assessment and evaluation of these strictures.